Good afternoon, everyone. Hope everyone is doing okay. Here, here we are to discuss today's presentation on assessment of excessive daytime sleepiness, and I'm Dr. Poojitha Sushma Malla. Starting with why the assessment of daytime sleepiness is important is because it is associated with significant morbidity. Sleep disorders, even though they are very common, we get patients here every day who complain of excessive daytime sleepiness and snoring in their sleep. And there are so many people like that out there, but there's not much sleep research happening or many sleep studies being conducted or sleep study facilities available. So around 33% adults, they report excessive daytime sleepiness. And this is not an age-related issue because 41.5% of the adolescents also complain of this issue. And in total, it results in functional impairment in about 15.6% of the adult population of US. And not just functional impairment in such a sense that it could affect both the learning. If there's a child, they usually sleep in the classrooms, and this affects their learning. And even at work, people report sleeping, excessive sleepiness, it decreases their productivity. And even in some cases, it could be life-threatening as well, as we can see in the next slide. There are a lot of people who get into life-threatening accidents. We have a patient who even got into a life-threatening accident because of this, and this is not a rare thing as well. About I have read a case study that informed that about the accidents that are caused by excessive daytime sleepiness. They have a peak in the afternoon, and the deaths that are caused by excessive daytime sleepiness and accidents caused by it is almost equal to the accidents caused by alcohol intoxication. Before we start more in-depth discussion on this topic, we need to understand what excessive daytime sleepiness is when compared to hypersomnolence and hypersomnia. So what is the difference? In international classification of sleep disorders, usually hypersomnolence is described as a symptom, but hypersomnia is used as a part of a disorder. For example, idiopathic hypersomnia. But in DSM of mental disorders, usually hypersomnolence is used as a disorder, like hypersomnolence disorder. And it usually refers to patients who feel excessive daytime sleepiness with multiple sleep attacks in the morning. And they feel they don't feel rested even after their sleep. So, but in our discussion, we are going to concentrate more. We can use hypersomnia, but we won't be using hypersomnolence because it is used in many places with different meanings. Coming to the common presentation of excessive daytime sleepiness, of as the saying goes, feelings of excessive sleepiness. And these people, they fall asleep very suddenly, very quickly, and these are called sleep attacks. And nighttime, usually even after they sleep at the night, they remain unrefreshed the next day, and they take multiple naps in the same day. And sleep inertia, this is just difficulty in getting up from the bed, and it is very difficult for them to wake up whenever they sleep, even in their naps in the day. So what would you report as the most common cause of excessive sleepiness? Do we have any answers from anyone as to what they report as the most common cause of excessive sleepiness?
Insomnia?
Exactly. So most of the people, insomnia, as in, can you expand on that? Is that like a disorder you mean? Insomnia? So usually whenever we see excessive sleepiness patients, we try to get to a diagnosis, but the most common cause, which is the most simple cause, is insufficient sleep. And this doesn't need to be because of a disease, as all of us know. It could be just because they are usually individuals who do not sleep for enough time. For example, a lot of Americans, in American Academy of Sleep Medicine. For adults aged 18 to 60, it is at least required that they sleep 7 hours a night. But we have a lot of people, about one third of the population. I've read in one of the studies and mentioned that most of one third of the adult population gets less than 7 hours of sleep per night. And coming to the other causes that we have to rule out, it would be physical comorbidities, like, for example, weight gain, obesity. They usually increase the risk for excessive daytime sleepiness, including increasing the risk for sleep apnea, diabetes mellitus, breathing disorders, asthma, GERD. We often hear patients mentioning that at night they just stop breathing.
Mhm.
So, and psychiatric conditions, for in particular the mood disorders like bipolar disorders. And this interaction is particularly interesting because psychiatric conditions, they cause excessive daytime sleepiness, and excessive daytime sleepiness, it increases the chance of further attacks, acute attacks of these mood disorders as well. And next, circadian rhythm sleep wake disorders like delayed sleep wake phase disorder or jet lag disorder. In these cases, usually the cycle in which the person works on, that is not the socially accepted cycle. So in jet lag disorder, we see it, and even in people who do night shifts commonly, even in them it is very common. And central disorders of hypersomnolence is what we usually deal with very commonly in our clinic as well, like narcolepsy type 1, type 2, idiopathic hypersomnia, Klein-Levin syndrome. And central disorders of hypersomnolence, narcolepsy. Coming to narcolepsy, it is severe excessive daytime sleepiness with cataplexy in about two-thirds of the patients. And narcolepsy, it has type 1 and type 2. So type 1 has cataplexy with EDS, and cataplexy is very common in type 1. But type 2, it does not have cataplexy acts as commonly as type 1, and usually it is said to not have it. And but rapid eye movement phase disorders, uh, abnormalities are common in both type 1 and type 2. And idiopathic hypersomnia, it has excessive daytime sleepiness with no cataplexy and no rapid eye movement sleep intrusions. And one difference that I've also found between narcolepsy and idiopathic hypersomnia is people, they take a lot of naps in the daytime. So we hear people who have narcolepsy, and they mention that they nap a lot of time. We have a patient who has to sleep 16 hours a day, but she mentioned that when she was taking 16 hours a day sleep, she was actually very rested. She felt very rested. In idiopathic hypersomnia, that is what does not happen. Like in idiopathic hypersomnia, people continue to sleep, they take naps, but they don't feel rested after the naps. They don't feel rested after the night, after waking up after the night, nor after any of the naps as well. And Klein-Levin syndrome, that is a rare disorder mostly seen in adolescent males. And this is a syndrome that is usually that is remitting, relapsing kind of a presentation with 2 weeks. Usually it lasts around 2 weeks, and it recurs every 18 months usually, with a person having excessive sleepiness, cognitive impairment, altered perception. And along with this, they have other symptoms also, like eating disorders. They could have anorexia, bulimia, and they could be having disinhibited behavior, and loss of concentration, attention, all of these. But all of these, they usually resolve after that episode. So between that episode and the next episode, the patient has absolutely nothing and they are absolutely fine. But again, the next episode comes up. But this is still not a very serious problem because it resolves spontaneously by 30 years of age. Now, as we have discussed, common narcolepsy symptoms, they are excessive daytime sleepiness, bouts of muscle weakness, cataplexy. In this case, what happens is suddenly there is a loss of tone in muscles of face, limbs, neck. Sometimes the neck just falls and they have weird facial movements. And sometimes the legs give away and they fall as well. And hallucinations are one of the more common symptoms as well, with people mentioning about hypnopompic and hypnagogic hallucinations. So hypnagogic are hallucinations that usually they have when they're going to the sleep, while the latter is when they wake up from the sleep. And sleep paralysis is also because the REM sleep, rapid eye movement sleep, it intrudes into the wakefulness, the time that the patient is awake. So the patient is awake, the eye is open, but they can't move any of their body parts, and it feels like they're just limp, flaccid, and they're just paralyzed. Along with this, narcolepsy has other symptoms as well, like restless leg syndrome. We could see them associated with narcolepsy. And one interesting symptom that I can't get it out of my mind for some reason, and these symptoms are seen a lot as well. One patient that I met, she had a REM sleep, a rapid eye movement sleep that started within 5 minutes of her going to sleep, and because of the very small gap between this, she usually can't differentiate between reality and her dreams, and she has a lot of dreams as well. So after waking up the next day, she could not possibly distinguish between what is real and what is a dream. So she has to take the help of her kids every day to go through everything that happened the day before, so she could distinguish between what was real and what was just her dream. And one other very interesting symptom that narcolepsy has is automatic behaviors, in which the patient, they sleep suddenly, and in the sudden sleep attack, they it could happen while they're doing anything. So, for example, in this case, the person, she is writing, she's studying, and usually they fall asleep and they would continue to do that activity. So there is a person who's studying. She studied for 35 minutes. Now she's starting to fall asleep. So now she fell asleep. This is the point when she fell asleep. She continued to write, she continued to scribble on her paper like she was doing. All of these, the interesting thing is, all of this, she's still sleeping. She wakes up after a while, she checks everything, and then she realizes that she was confused the whole time. She's trying to understand what is happening. She sees the scribbles. And this is a very common thing. In narcolepsy, they wake up, they see scribbles, they see things that they were doing, and they have a lot of confusion after waking up. So now, now that we have learned about all the causes, now coming to the assessment. History. History is one of the most important things in excessive daytime sleepiness assessment. We start with the most basic things, like what is the time that they go to bed, when do they wake up, in weekdays, weekends, and we will know if the person is just not taking enough sleep, and if they're just not choosing not to sleep enough, and that is why they are having it. Or total daily sleep time and sleep habits. For example, do they snore in their sleep? Do they move a lot when they sleep? Do they have cataplexy when they sleep? So all of these are very important. Like for example, periodic limb movement disorder, they might know, usually the people who are their bed partners, they would know more if they have periodic limb movements, and because of that as well, the sleep could be disturbed, and they must be having uh, excessive daytime sleepiness. And other than that, we can ask about additional history for respiratory conditions, asthma, GERD, psychiatric illnesses, and collateral history can be collected from the bed partner about if the person is snoring at night, or if they see any movements of the limbs, if they're having cataplexy or any abnormal behaviors when they're going into that deep sleep. And another very important thing that we should never forget in sleep disorders is to ask about the medication and substance use. So antihistamines, here's a list of all the medications that can affect the sleep, like antihistamines, non-prescription sleeping pills, and alpha-2 agonist benzodiazepines, and alcohol. One of the very important things is also alcohol. And not just taking drugs, but also withdrawal. We have to consider, maybe the person just stopped taking caffeine. People who take it a lot of caffeine for a long time and suddenly they stop taking it, they must be having substance withdrawal. And even in cocaine, this happens. Now, fatigue versus sleepiness. In clinical practice, we need to understand to differentiate between both of these, because some people, the patients, when they say, they kind of confuse between fatigue and sleepiness. So I do recall asking if they feel really sleepy in the daytime, and they would be like, yeah, I feel pretty tired. And so we need to understand what is the difference between fatigue and sleepiness. Fatigue is they are generally not able to do physical activities that they might have done better before, but they are not able to do now, or even mental activities like concentrating attention. It is not as good as it can be, and this could be attributed to any neurological, psychiatric cause. But sleepiness, usually it is very sleepiness is usually, if you see it, it is very clear that excessive, they are having a lot of sleepiness, and you can attribute it to sleep disorders, and you can evaluate more in that way. So this also, if you know how to differentiate between fatigue and sleepiness, then we can also go decide which route we are going to take in the assessment. So measurement of the sleep, we use three most common scales. That is Epworth Sleepiness Scale. It has total eight items, and it assesses overall sleepiness and likelihood of falling asleep in different scenarios. So it gives you a lot of scenarios, and you need to grade it from 0 to 3. And if it is 11 or more than 11, that means that you have excessive sleepiness. And Stanford Sleepiness Scale, it has 7 points and measures at that point in which the test is happening. So it has from a very alert to very sleepy. And Karolinska's sleepiness scale is also very similar to the Stanford sleepiness scale. And this one has 9 points from extremely alert to extremely sleepy. The point to note here is Stanford sleepiness scale and Karolinska sleepiness scale, they measure the sleep at that given point of time. But Epworth sleepiness scale is more, it has questions that grade over a period of time. Like the patient has to recall, and then it assess more in a clinical way. Epworth sleepiness scale assess the sleep, but Stanford and Karolinska, they are usually used in research, and they give the effect of a drug probably. So they are usually used in trials research. Physical examination, we can check for the level of alertness, the BMI, neck circumference. As we all know, it increases the risk factor for obstructive sleep apnea, and other physical abnormalities like mid-face hypoplasia, micrognathia, retinognathia, and enlarged tonsils, deviated nasal septum. These all make breathing difficult for the patient. They might be having breathing problems. They might be able to get up at night, and sleep disturbances. Signs of insulin resistance, acromegaly, hypothyroidism as well are very important. And circadian rhythm sleep-wake disorders or narcolepsy, idiopathic hypersomnia, these usually show normal examination. Although there is one thing that we could note, that narcolepsy, usually when the patients come in, there is less probability you will be getting to see a cataplexic episode right in front of you. But if you do get to see a cataplexic episode happening right in front of you, then you can try to elicit reflexes, because for a point of time after the cataplexy, the person would be having areflexia. So if you can elicit that, then it becomes a very sensitive test for narcolepsy. It is very specific for narcolepsy. And suspected central disorders of hypersomnolence targeted neurological examination for all the suspected areas of brain. For example, brain stem. You can check based on what disorder you think they might be having. So three modalities that you'd use other than the physical examination history are actigraphy, which is a non-invasive and very inexpensive procedure. You just have to it is like a surrogate marker for sleep and wakefulness. So it just measures over a week, over a period of time, how much sleep the patient is getting, how much deep sleep the patient is getting, how long are they awake. It might overestimate the amount of time that the person is awake, but it is still a very good assessment for to know how long the person is sleeping and how long the person is awake. And polysomnography, they usually have a lot of lists that assess eye movements, respiratory EEGs, and ECGs in some cases, and it entirely measures the deep rapid eye movement phases and the all the phases of the sleep, and how the latency and how fast is every stage going by. And by this, we make a lot of diagnoses as well. And gold standard for narcolepsy is MSLT, and it is sleep latency test. And in this case, you after the polysomnography, you make the patient take 4 naps in 2 hours with gap of 2 hours, and you need to get short onset rapid eye movement phases, SORMs, 2 or more than 2, for it to be
Wait,
diagnosed as narcolepsy.
I'm just finishing up. Okay?
Yes. And in MSLT, that is what it diagnoses. It is after
What?
this in narco. Yeah, yes, Dr. Sain.
Are you home now? Okay. I can't talk. I really
So,
can't talk.
so narcolepsy type 1, usually type 1, type 2, and idiopathic hypersomnia. These are mainly the ones you have to differentiate. So type 1, it has MSLT less than MSLT means sleep latency less than 8 minutes, and at least 2 sleep onset rapid eye movement periods, which is SORMs, on MSLT and PSG, and cataplexy is present. If not these, you can also check for the CSF hypocretin one, and it would be less than 110 picogram per ml, or it could be less than 1/3 of mean values obtained in normal subjects with the same standardized assay. But CSF hypocretin 1 concentration is almost equal or very less decreased in narcolepsy type 2 and idiopathic hypersomnia. Mean sleep latency is less than 8 in the other cases as well. But SORMs, they don't need to be more than 2. They are usually less than 2 in narcolepsy type 2 and idiopathic hypersomnia. There is also some of the reports that suggest that it could be a narcolepsy spectrum in which narcolepsy type 2 and idiopathic hypersomnia could be assessed, it could be placed at, but it is still not used in mainstream. To help diagnose narcolepsy, CSF hypocretin levels can be used, even though using polysomnography and the symptoms of cataplexy and excessive daytime sleepiness, they are very much enough. But in some cases, for example, if the patient has untreated OSA, they are going to have a abnormal sleep test. So we also prefer doing CSF hypocretin 1 levels and shift jobs and psychotropic drugs. In some cases, the psychiatric drugs, they act as a confounding factor in the sleep study. But if we stop them, the person might have a manic attack. So we don't prefer to stop it, and we will do CSF hypocretin 1 levels. And if they're less than or equal to 110 picogram per ml, then we usually say that it is diagnostic of narcolepsy. We can also check for HLA DQB1 0602, a HLA antigen seen in 90 to 95% of African American white Japanese patients with narcolepsy type 1 and 45 to 50% with type 2. But important point to notice, 25% of the general population also has it. Now, overall, the algorithm for the evaluation of EDS is symptoms of sleepiness. The patient usually comes with the symptoms of sleepiness. You describe, first of all, by differentiating it. Is it sleepiness or fatigue? If it is fatigue, then you can determine its causes. If it is sleepiness, then you go by checking for insufficient sleep, or if the patient works in shifts, then you advise life changes. And if the patient has a sedating medication or uses recreational drugs, then you have to counsel them regarding it and adjust them as indicated. If the patient has snoring, snort arousals, or observed apneas, then you do a polysomnography test or home sleep apnea test. If no cause is found or sleepiness persists after all of this correction, then we do an MSLT to assess for narcolepsy or idiopathic hypersomnia. Coming to the treatment, most important part to understand in treatment is to ensure sufficient amount of sleep. So if it is caused by another condition like obstructive sleep apnea, psychiatric illnesses, then we treat the psychiatric illness better, or we need to give a CPAP machine. But in other cases, there is no cure, for example, narcolepsy, but stimulants like methylphenidate and behavior modifications like scheduled naps. They schedule their naps over the day, and cognitive behavioral therapy, sleep hygiene, exercise, and distraction techniques. Like some people are asked to chew gum over the day so that they have something to distract themselves from the sleep. For the treatment of EDS in narcolepsy, modafinil, armodafinil, these are some of the drugs that are FDA approved. And this algorithm is developed balancing the current evidence base and abuse potential of the drugs and side effect profiles. So we have to understand all of this, and we have to suggest a drug. Now, after all of this discussion, I would like to ask this question about a case that I've read. A 44-year-old woman who gave an 18-month history of excessive daytime sleepiness, hypnagogic and hypnopompic hallucinations, cataplectic attacks, and migraine headaches. Her cataplectic attacks consisted of a sudden bilateral loss of motor tone in her facial muscles and upper limbs, as we have talked about, her head dropping forwards and her eyes closing, and her not responding to her names being called. These attacks, they lasted minutes and were triggered suddenly by intense periods of emotion such as fear and anxiety. It sounds so far a lot like narcolepsy. She did not have sleep paralysis or any automatic behaviors. In the initial consultation, it was noted that she likes to be ill, but it was not taken note of. And the neurologist was treating her headaches with an anti-migraine medication. Computer-enhanced topography and EEG were normal. So this patient was asked to get an MSLT, and in the MSLT, she was found that 4 out of the 5 times she had a short onset rapid eye movement, which she progressed into the REM stage within 30 seconds of going to sleep. And she had less sleep efficiency as well, and sleep latency was very less as well. And she slept within 2 minutes almost all of the times. And all of this diagnosis, it really points towards narcolepsy. Does anyone have any doubts till here, or that it is probably not narcolepsy? Okay. But we found out that the patient was given medication for this, And 6 months, she did not have any symptoms. 6 months, the patient was entirely active. The patient was doing well, but after 6 months, she suddenly presented with new symptoms. She had psychiatric symptoms, and she was admitted into a hospital. And the husband of the patient, he was taken away, and the doctor talked to the patient as well, trying to counsel her when she has confessed that she has relationships with her primary care physician or physician, and it was causing a lot of stress to her. And she asked the doctor to not disclose this to the husband, so he did not. And she was admitted to a ward. And after a week of her symptoms, which got worse and worse, she had more migraine attacks, she had more cataplexic attacks. And after 1 week of these symptoms, she disclosed all of the secret to the nurse and her husband. And to everyone's surprise, the patient started becoming normal again. Her cataplexic attacks stopped. Her MSLT, that was sleep study that was done later, it showed sleep latency of 9 minutes. And her REM sleep, it was not within 30 seconds like it was. It just correlated more to a diagnosis of depression. So after assessing further over a period of time, she entirely lost all kind of excessive daytime sleepiness. Even the migraine attack stopped, and this was all attributed later to conversion disorder. That was mainly because she wanted the attention from the husband. So it could be because in the beginning of this illness, right before in the beginning stages of the symptoms, one symptom that the husband was talking about was he opened the door and the patient fell into his arms. So uh, this was later, the doctors thought it was cataplexic symptom, but later on it was decided that when she fell into his arms, the husband was worried. He gave her some kind of extra time to her. So she has associated all of the symptoms, she somehow connected it, and she had a whole presentation that is very much like narcolepsy. So our conclusion is the excessive daytime sleepiness, it is a potentially hazardous condition. It has many etiologies, and we need to treat it and assess it as early as possible to avoid loss of time to the patient, loss of opportunities, problems at work, and even life-threatening complications. And evaluation of excessive sleepiness should include targeted tests conducted under ideal circumstances to avoid spurious results. Medications are the mainstay of the treatment for central disorder. So some of the studies mentioned that some patients for narcolepsy had to change 7 doctors to actually get a sleep study. So one of the main reasons that I wanted to talk about this topic was that because that should not happen. A patient should not have to go through so much to get the treatment that they really need. Thank you.
Okay, stop recording.